All right, let's begin. So we ended last week with the settings on a ventilator. Any questions on the settings? Proceed with the modes. All right. We will skip over the types of ventilators. This part here is referring specifically to the vent being used in a certain hospital. There are several types. There's pressure cycle, time cycle, volume cycles. That's not our concern. Our concern is the mode, because ventilators vary by brand, but the settings and the modes are constant. Right? Each ventilator is capable of, you can put the same settings, they're capable of the same mode. So we will skip over the type because that's not the testable part. Let's go to the mode. Now, you have to remember that ventilators is going to either support or take over the patient's work of breathing. So it is all about who does most of the work of breathing. For instance, so it's all based on work of breathing. This is usually shared by the patient and the vent. So the patient and the ventilator. The mode will tell you who does how much of the work of breathing. For instance, there is a mode which is not in your textbook. I just want to explain this mode. That way you can understand the 2 or 3 modes that is mentioned in your textbook. There's something called control mode. The control mode, the ventilator controls 100% of the work of breathing, meaning the patient has no say in the breathing at all. Now imagine yourself under something over which you have no control over. Let's say your grade, for instance. Let's say the instructor bases your grade on how he or she likes the student, not based on exams. Or let's say the NCLEX. The NCLEX will base your score or your whether or not you pass based on how you do one particular, how you sit in front of the computer, for instance. Right? So you have no control over that. How would that feel?
Annoying, frustrating, bad.
Right. So how would you feel if you were put on a ventilator wherein you cannot control how or when you breathe? The machine is 100% controlling how or when you take a breath, how much air you receive, when and how often. Would that be nice? Somebody has control over your breathing, which is one basic thing all of us need. No, the only thing the control mode will work is we have to paralyze the patient. The patient must be paralyzed. So the only time the control mode is used is in surgery, particularly somebody who is under general anesthesia. Because as you learned in 3rd semester when you talked about chapter 15, intra-op, now a patient undergoing general anesthesia receives 3 basic medications. One is the anesthetic, the other is a pain medication, and the third is a muscle paralyzer that is called succinylcholine, if you remember. Succinylcholine will paralyze the patient. Therefore, if the patient's paralyzed, then of course, can they breathe? Because it paralyzes everything, including your diaphragm. Can the patient breathe spontaneously?
No.
No.
So it is therefore necessary to intubate the patient and put them on a ventilator. And this is the only time the control mode is used in general anesthesia. All right, you will never see this in any other unit in the hospital, ICU, PACU. Nobody else uses the control mode, only in surgery when a patient receives general anesthesia. So here, the work of breathing is 100% vent only. So all other modes, which we will talk about in chapter 32, are shared between the patient and the ventilator. It's just a matter of how much work of breathing does the doctor want the patient to do? How much work of breathing does the doctor want the ventilator to do? Okay. Now, one thing to remember is all our modern ventilators are all positive pressure now. When we first discovered or invented the ventilator, the very first were negative pressure. They mimicked the human body. So how we breathe is, it's all done by our diaphragm. So unconsciously, the diaphragm contracts down. Air is sucked in passively into our lungs, and then the diaphragm relaxes or rises back toward the chest, and then that pushes the air out. So therefore, our breathing is effortless, and we are negative pressure ventilators, meaning because the atmosphere pressure is higher than what's inside our body, we are negative pressure ventilators. So air is sucked in passively without us knowing it, 12 to 20 times per minute. The diaphragm does our work of breathing. So we are negative pressure ventilators. The negative pressure ventilators first invented were very cumbersome. They were like cylinders. They were either like this, and we put the patient in there, only the head is sticking out. The rest of the patient's body is in there. So there are tubes connected to the ventilator, which creates a vacuum, allowing air to be sucked into the patient's lung. Now imagine if our modern ventilators work like this. How are you going to assess the patient? How are you going to clean doo-doo? How are you going to turn the patient? How are you going to change them? So negative pressure ventilators obviously did not work very well. It wasn't conducive to caring for the patient, because each time we need to turn or assess the patient's lung sounds or check their skin or any other assessments done, we have to interrupt the therapy. We have to take them out of the cylinder and then do whatever we need to do. So therefore, you can understand why they didn't last long. So now came positive pressure ventilators. So it doesn't work like our body. So in positive pressure ventilation, we have to, the machine, the vent has to push air into the patient's lung. So that is now how our ventilators work. Okay, there are two main modes. We have what's called volume modes, and we also have what's called pressure modes. So let's begin with volume modes. They're called volume because there is one thing that is preset. Two things actually that are preset in AC. So let's begin with assist control ventilation. This is a volume mode, in the sense that, as described here, the tidal volume and the rate are preset. What is tidal volume again?
It's the amount of air that's pushed into the lungs.
All right, for each breath, right? And then the rate is obviously the frequency. How often is that tidal volume given every minute? So to calculate minute ventilation, we simply multiply tidal volume times the respiratory rate equals minute ventilation. So since it's a volume mode, it will deliver a minimum amount of air or breaths in a given minimum amount of frequency. So let's say we So let's say the tidal volume is 400 ml. And then the rate is 12. So if the vent will give you 400 ml of air with each breath 12 times a minute, again, multiply that will be your minute ventilation. So about how many seconds will the vent give you a breath if we set the frequency at 12?
Every 5 seconds.
Very good. 60 seconds divided by 12, so every 5. So let's illustrate that. So let's say this is your zero pressure, and the vent gives you a breath here. Then 5 seconds later, another breath. And 5 seconds later. All right. So all good. However, the patient is allowed to breathe in this instance. In this mode, the patient can trigger spontaneous breath, meaning in between ventilator delivered breaths, the patient can also take their own breath. However, because this is a assist control by the term itself, it will assist the patient. However, it also maintains a certain level of control, meaning the patient, there's no way the patient will receive less than 12 breaths. The machine, the vent, will give 12 no matter if the patient breathes or not. The patient will get a minimum of 12 breaths per minute. The patient has no control over that. However, if the patient triggers spontaneous breaths, the machine catches the patient's trigger, meaning there's something called, there's a setting on the vent, which I didn't mention, nor neither did the textbook mention it. There's something called sensitivity. Sensitivity is usually negative around 0.05 centimeters of pressure, meaning that we are negative pressure ventilators, right? So if we trigger a breath, the patient takes a breath, that means the diaphragm contracted down, and therefore the vent will sense the negative pressure coming from the patient. When that happens, the patient will receive 400 ml. Let me illustrate. So this is 0. If the vent gives a breath here, for instance, okay, and then a few seconds later, the patient initiated a breath. So the patient's the pressure became negative, and then the vent sensed that negative pressure. The vent will go ahead and give the patient the preset tidal volume. The patient will receive 400 ml. Although the patient can control the frequency of the breath, meaning the patient can add to the 12 if the patient chooses to. However, the patient has no control over the volume. Meaning in between these breaths here, the patient is allowed to breathe. They can initiate a breath. However, the one thing they cannot control is the tidal volume. They cannot control how much tidal volume they receive, because it will be the vent that is in charge on that part. So the only thing the patient can control is the additional rate. The patient can breathe faster than the vent, never lower though, because again, the vent will deliver 12 regardless. And the other thing the patient can control here is the tidal volume. So this is how you will go. So this is another vent breath, and this is another patient breath. However, again, the tidal volume remains constant. It cannot change because that is what you preset, right? Again, there are two things preset in assist control. There's a preset tidal volume and a preset respiratory rate. So this is the most common. Almost all patients are first put on AC. Let's say a patient goes into respiratory failure, becomes a complication of ARDS, for instance, or just simply was found unconscious. So every everybody is put on assist control. Any question on assist control?
So here they can control the frequency, right, but not the volume and the respiratory rate.
They can add to the respiratory rate. So to a certain extent, yes, the patient can control the rate because they can increase the respiratory rate because they can add to it. However, they cannot change the tidal volume. Every time they attempt to breathe, the vent delivers the preset tidal volume. So this is what it means by the patient can control the rate of breathing, but they cannot control the tidal volume. The amount of air they receive with the spontaneous breath remains constant. Any question besides Ms. Lam? All right, let's go to the disadvantage now. As you can see, we never like having no control over something, right? So like this one, for example, we cannot control the tidal volume. That can be a problem because as this patient gets better, that means they will start taking more spontaneous breaths, correct? Let's say they add 8. What if they add 12 now? What if they're getting stronger and now breathing better, breathing faster? So if they take 12 breaths on their own, plus the 12 that the vent delivers, because again, the vent will not give less than 12, regardless of how many breaths the patient takes, how many spontaneous breaths the patient takes, the vent will not lower the 12, because that is the preset rate. The vent is programmed to deliver 12 regardless. However, it's also programmed to assist the patient whenever the patient initiates breath. So every time the patient initiates breath, the vent will also give that breath on top of the 12. So what could result here? So if patient's taking 12 and the vent gives 12 minimum, what will happen to the patient? As stated here, right, the patient's breathing rate will increase. Your minute ventilation here increases, causing hyperventilation and therefore respiratory acidosis. Because there are non-pulmonary causes of increases in the respiratory rate. These are some of the causes: pain, anxiety, or acid-base imbalances. If the patient experiences these, that will affect your respiratory rate, right? Because in pain, yeah, of course, you're in pain, so the patient's respiratory rate will increase. Or if they get anxious, one cause of anxiety could be hypoxia. Another could be, let's just say they're off sedation. Okay, the sedation bag is empty. The nurse forgot to replenish it. So now the patient's not receiving any sedation or pain medication. So now the patient's more awake and they're confused what's going on. You know, they have a tube, they can't control, they can't breathe. So that will, of course, affect their respiratory rate, resulting in hyperventilation. So this is one reason why in any setting, any mode, you must watch your patient every hour. So you have to monitor the patient. Is your therapy still appropriate? Is the patient still, do they need to be in the same mode? Is it time to change the mode, or is it time to change some settings on the ventilator? Any question on assist control?
So, so if you have to change the rate, can we change the rate from 12 to 10 or something? Or if
It will be, it will not be advisable to drop the respiratory rate less than 12 on assist control. It's not safe because I'll show you. If we drop that, okay, so if we, let's say, drop that to 10, what if this patient stops breathing?
So
How many breaths are you giving now?
So,
Patient receives 10, right? So if the patient gets better though, if the patient after drawing ABGs, which is the only thing you can do because the patient most of the time is sedated. So you constantly evaluate the ABG. By the way, you draw ABGs every time there's a change in the mode, a change in the setting. Anytime you make changes on the vent, you have to draw ABG to see how did that change affect the patient. How did that affect the patient's respiratory function? Because remember, these patients again cannot tell you, they cannot speak, they are sedated. So every time you make changes, the only way you can evaluate the effect of that change on the patient is to draw ABG within about 30 minutes of the change. All right, so that is assist control. So let's go to
Professor, is assist control considered invasive?
SIMB. Hello?
Yeah, I just had a question. I was wondering if this was considered an invasive mode. I don't know what that means, but
When you intubate the patient, yes, it's
okay.
already invasive. I mean, you put a breathing tube down the patient. So yes, all of these.
Oh,
are
okay, all right. Thanks.
So let's go now to the next mode, SIMV. So this is still a volume mode, and as described here, this is similar to AC. This is a volume mode. There's a preset tidal volume, and there's a preset frequency or preset rate. However, unlike AC, wherein when the patient takes a breath, the vent gives the tidal volume, correct? In SIMV, if the patient takes a spontaneous breath, who determines the tidal volume? Is it still the vent? Read the highlighted statement.
Professor, you're breaking up.
Is it still the vent that determines the tidal volume for a spontaneous breath?
No, is it the
Not
patient this
anymore.
time?
It's the patient now. Again, so let me illustrate how this works. So obviously, this mode is only used more frequently as a weaning. It can also be used as a main vent mode. However, it can be also dangerous because just like the question I asked earlier, what if this patient stops breathing spontaneously? So SIMV is used more if a patient is already starting to be weaned. I mean, I've seen them use it as the main vent mode. However, it's usually for a better patient. So if the patient is getting better, meaning they're taking more spontaneous breaths, their ABGs are looking good, meaning they're ready to come off the vent and then start breathing on their own. So this is the mode we use, SIMV. All patients always start at assist control. When a patient needs to be intubated, the first mode we use is always the assist control. Except of course the OR, and it was the control mode. So again, SIMV is still a volume mode because we have a preset volume and then we have a preset rate. So let's say this is the patient's, this is the vent breath. Okay. And then you notice I never put the
Professor, we
to zero.
cannot hear you.
Remember we talked about P this week?
Professor Espardo?
Can you hear me now? Hello?
No, man. We can't.
All right. When did you lose me?
I'd say about 30 seconds ago.
Okay. All right. So here is SIMV. So again, it is a volume mode. There is a preset tidal volume. There is a preset rate. So to illustrate how the patient breathes in this mode, so this is again the ventilator breath. You can see again it's a vent breath because it starts from above zero. So it starts from zero going up. If it's a patient initiated breath, it always goes negative, so below zero. So SIMB, preset rate, preset tidal volume. So let's say we have a tidal volume of 400 and a rate of 12. So every 5 seconds, the patient gets a breath. If the patient takes a spontaneous breath, it'll go negative. This time, unlike assist control, wherein the patient receives the preset tidal volume, this time, no. The vent allows the patient to determine how much tidal volume they want. So if the patient is still starting off to get better, he or she may take a small tidal volume, like that. Or the next time, the patient may take more. They may go like this. So here are the patient's spontaneous breaths. They can take less or more than the preset tidal volume. Is that clear?
Yes.
Any question on SIMV? So this is the main difference between assist control and SIMV. So it seems more comfortable, does it?
Yeah. How about
Does it sound more comfortable?
yes? But how about the rate? Rate they can also increase and decrease.
Usually, if SIMV, remember, SIMV is used if the patient is getting better. By better, meaning is the patient taking more spontaneous breaths?
Yes.
Yes. So that's as here, if you look at this statement here, when used for weaning, the number of mechanical breaths is gradually decreased from 12 to 2 as the patient resumes spontaneous breathing. So as the patient gets better, we gradually decrease the rate on the vent, the preset rate on the vent, from 12 to let's say 10, and then the patient, we always draw ABG. The ABG show it's normal. We drop it further to 10, from 10 to 8 to 6 to 4 to 2, and then finally we will extubate the patient.
So we have to do that manually, or it will be done by automatically by the machine itself.
Do what exactly manually?
I mean the rate, to decrease the rate of the breath, 12 to 10, 10
You
to
mean
8.
when you have to do it manually. We can't set it automatic because you have to check the patient first. Yeah, the vent won't know whether or not the patient is getting better or not. It's still a clinical judgment. Okay, remember that the vent is only a tool. It's only as smart as the user. The vent is not, I mean, it's a computer, but it doesn't have artificial intelligence. It's still at the whim of the user. So it's still the nurse and the doctor controlling the ventilator. Right?
Professor, is there specific labs that we need to know in order for the patient, in order to determine what a patient has to meet in order to qualify for the SIMV?
ABGs.
What specific rate?
Remember in assist control that the patient, if they get better, usually what will happen to the ABG result? if they take more breaths in assist control.
So we don't have to know a specific number, just an improvement that they had before, or
Yeah, of course. Because if the patient gets worse, are they ready to be taken off assist control?
no?
No. So let's say the patient goes into respiratory acidosis. So that means, is the patient taking more or less breaths?
Less.
They're taking less. So
Less, yeah.
yeah, so they're not ready to be taken off assist control yet. So the doctor will try either increasing FiO2, or depending on his assessment, let's say the patient goes from respiratory failure to now ARDS, then of course that will delay the patient's progress. Okay, they'll have to stay on assist control a little bit longer.
Okay, thanks.
All right. So it's again, your whole basis here is your ABG. So you draw ABGs constantly, and don't worry about drawing ABG because these patients will have an arterial line. So you can draw ABGs from that arterial line as often as you want. You don't need to call respiratory therapy to draw ABG for you. Because there will no longer be arterial sticks. You don't need to. You have an arterial line. All right, so those are the two basic volume modes. Let's go to the other modes. Bipap. Remember last week we talked about this as a setting. It is also a mode on the vent. You can use the vent as a Bipap. Again, Bipap when used on the ventilator, meaning if you use a vent as a Bipap, then of course that means you are trying to wean the patient already. But this is further in the therapy when the patient is getting better, so you can just put them on a Bipap. However, the patient is still intubated that way. Should they go back down, meaning if they go back bad again, say for instance they have respiratory muscle fatigue or respiratory failure again, then you have no problem. You still have an airway. You still have the ET tube. You can simply turn on the vent again and then resume assist control. Those are the only two I am discussing. There's one later. Let me go forward, and then I'll go back to nursing management. Just want to show you the pressure because I only showed you two volume modes. There is a pressure mode under.
Professor, sorry, it's breaking up and we can't see the screen at the moment.
Can you see it now?
No.
No.
How about now?
No.
No. So it says that you're sharing, but it's just a black screen.
Mm.
And we can see it now, Professor.
Yeah, there we go.
Okay, I'll go back to nursing management shortly. I went forward to page 635 under weaning, table 32-7. So as I mentioned earlier, SIMV can be used as a weaning method. TPs is when you completely remove the patient from the ventilator and just have them breathe through the ET tube. The TPs is just the adapter for the ventilator circuit. Think of it as the patient breathing through a straw. Okay, by straw, I mean it's the breathing tube that they are breathing through. Kind of like Rambo when he was, I forgot which Rambo movie that was, when he was breathing through he made a snorkel out of I don't know, some stalk of a plant, and he was breathing through that. Okay, think of it that way. That's the TP's technique. I'm here to discuss pressure support ventilation. So this is a mode. This is a pressure mode. If you notice in volume mode, the one thing constant was the tidal volume and the rate, correct? Meaning you can set the tidal volume and you can set the rate in volume mode. It did make a difference between SIMV and assist control modes because they were both volume modes. They had a preset tidal volume, they had a preset rate. In pressure support, this is a pressure mode. There is no preset tidal volume, there is no preset rate. The only thing preset here is pressure. Now, is pressure a breath? If a ventilator gives pressure, is it giving a breath?
Yes.
Is it? Because there is no tidal volume. There is also no rate, no frequency, no tidal volume. So is the ventilator giving a breath in a pressure mode?
No.
No, it does not give a breath. So therefore, can you use it as a main ventilator mode?
No.
No, that's why it belonged in table 32-7 because this is only a weaning mode. You can also use it together with a volume mode though, meaning if a patient is on assist control or on SIMV, for instance, you can add pressure support ventilation. So here, PSV allows the patient's respiratory effort to be augmented by a predetermined pressure from the ventilator. So when used alone, this is only used for weaning, meaning the patient has to be breathing spontaneously at a tidal volume that is consistent with human life or human survival and at a normal rate, meaning the patient has to be breathing on their own in order to be put on exclusively pressure support ventilation. Again, you cannot use pressure support ventilation alone when the patient is still bad. This is only used 100% as a weaning mode. You can use it together with SIMV, together with assist control, never by itself, unless you are weaning the patient. So here, it will only give a preset pressure. So it gives preset support, pressure support that way. So this means the patient is already breathing spontaneously, but needs a little more help. This is like the spotter of the gym. For those of you who go to the gym and then you're you're on the bench press, right? So there's a spotter there at working at the gym that helps you, especially if you get into trouble. So think of pressure support ventilation as the spotter at the gym. So you're doing things on your own. However, you just need a little bit of help in the process. Does that make sense?
Mm-hmm.
Okay, so pressure support, this is the only one mentioned in your textbook, so that's all I'm testing. So those are the 3 modes that will be on the exam. So we'll have assist control, which is the most common for all patients as we intubate them. And then we have SIMV as the patient gets better, and or as we're weaning. And then the other pressure mode here is the only pressure mode mentioned in your textbook is pressure support ventilation. All right, since these are all we have, that's all I am testing on the exam. I'll go to nursing management now. Okay, remember here I'll highlight this italicized statement. When caring for a ventilated patient, always check the patient first, not the ventilator. Okay, ventilator or the equipment will go next. So if anything goes wrong, you hear an alarm, look at the patient first. Don't look at the vent first. Okay, check the patient. How is your patient doing? Regardless of what the alarm says, whether if it's a high pressure alarm, low pressure alarm, check your patient first. Okay, and then check on the ventilator. Please read about ICU psychosis. I think I mentioned this last week. This is a common phenomenon. This is actually delirium. If the patient goes for days or weeks at a time with very little sleep, because sometimes it can't, we can't help it. The patient will have to be disturbed. The ICU is noisy, there's alarms going off. It's not just this patient. If it's not this patient, it could be the patient next door, right? Or it could be just the nurses being very noisy at the station. So think of it as, when you sleep deprive somebody, like you've heard what they do in Guantanamo, part of the interrogation process, it induces psychosis. The patient goes crazy because of sleep deprivation. So you'll see that in one of our best practice later. Actually, it was already mentioned last week under best practice. There was a chart, best practice for when caring for a patient under receiving mechanical ventilation. One of them was to give the patient as much rest as possible. That way they don't experience ICU psychosis. And of course, they heal better if they sleep better. As far as alarms go, we only have 2 alarms. We'll do high pressure and low pressure alarm. Again, there are several other alarms, but we'll only test high and low pressure alarms. So for your assessments, of course, the patient, you have to assess them as a whole, right? Not just respiratory function, but cardiovascular, their skin, any other body system. It's easily, I remember one time wherein we were so busy caring for the patient was going into septic shock, and we forgot to feed the patient. So we forgot to put in a NG tube or a PEG tube into the patient because she was going bad so fast. And and then at 5 o'clock I received a call telling me my patient's sugar was 5 milligrams per deciliter. And then so because we were so busy all day, and then we forgot, we were not feeding the poor patient. I already mentioned that monitoring the patient's response, your number one method here is to draw ABG. Okay, of course, that's just one of many, right? Listening to lung sounds, checking vital signs, etc. All right, alarms. I mentioned there are two, okay? This one was already mentioned earlier about condensation. I mean, last week in the chart, remember the statement that says never empty fluid that collects in the ventilator circuit back into the cascade. So this is again mentioned here again. Do not do not put it back into the cascade or to the patient. So just disconnect the circuit from the patient and then drain it into any receptacle. So here again, another action alert. So same thing. So that's 3 times already that we mentioned that any condensate, do not allow it to sit long there. Again, that will trigger a high pressure alarm because now there will be resistance between the patient and the vent. And that will again serve as a medium for bacterial growth. So let's go to high and low pressure alarms. First of all, if you cannot determine what's wrong with the patient, let's say you did all your best to determine what's wrong, you can't figure it out, it's best that you disconnect the patient from the vent and then just give them manual breaths until you can figure out what's wrong. Because until then, the vent, remember, the vent is not delivering any breath because the alarms are going off. So disconnect the patient, manually bag the patient. So just grab the ambu bag, give the patient manual breaths until help comes. And then if we can't figure out the cause, then we just get a new ventilator. This is no longer possible because we cannot turn off the alarms anymore. It's one of the safety features of ventilators now. It's impossible. The most you can mute it for 2 minutes, but you cannot turn off the alarm. Myself is also guilty about alarm fatigue because over time, when alarm keeps going off and you check it, or it's really nothing, it's just certain changes in the patient's airway diameter, wherein the alarm, high pressure alarm keeps going off because you already suctioned the patient, nothing's wrong. You tend to ignore it, just like the boy who cried wolf. No, the alarm keeps going off, but then there's really nothing wrong, and you made sure. That can be a cause of alarm fatigue, which can be dangerous sometimes, because now if you ignore that, what if it's really, just like the boy who cried wolf, what if there is really a wolf this time? All right, so just be conscious about that, because that can easily happen to you also. So we have table 32-5, we have high pressure and low pressure alarms. It tells you here why. So we have several causes, but all of them, if you look at the first column, all of them somehow leads to a mechanical obstruction or an increased resistance between the patient and the ventilator. For instance, here in an increased amount of secretions in the airway. Of course, now there's an obstruction there, or there is now increased resistance. So when the ventilator delivers a breath, it's meeting a lot of resistance. Will automatically trigger a high pressure alarm. And this is your corresponding action. That's what you do. So my question on the exam would be either multiple choice or select all that apply. I'll give you a set of causes, and then you determine what alarm will go off, or I'll tell you the high pressure alarm is going off. Which of the following could be possible causes? You have a list here. Or instead of asking me for the cause, which of the following actions are applicable in order to address this high pressure alarm? In which case, it will be column 2 as your answers. Any question? I won't read it for you. They're pretty clear. Here, for instance, the patient bites the tube. Of course, that will increased resistance because now the breath cannot go through because the patient's biting on the tube. Or this one, this frequently happens in assist control when respiratory alkalosis is happening, meaning imagine earlier this is another problem. So let's say Mr. Espinosa, if this is you, sir, so the vent gives you a breath here, right? And then through no fault of your own, because you're partially sedated, so you took a breath right after, right before the next scheduled breath. So let's say this is 1, 2, 3, 4, 5. The patient's supposed to get another breath here. 6, 7, 8, 9, 10. So we said every 5 seconds, right? So if the frequency is 12, let's say. So you're supposed to get another breath here, another breath here. Let's say you took the wrong time, you picked the wrong time to take a breath. You took a breath right here, right before the next breath. So remember, the vent gave you a breath here because you took a breath. And then before you could complete the exhalation phase, it's time for the next breath. So your lungs are still full. You haven't emptied it yet, but then it's already time for the next breath. You got another breath here. So this is called breath stacking. Just like pancakes. You have a stack of pancakes here. So you have 2 breaths given at the same time, one after the other. So will that make you go crazy?
Oh, it's not good.
Yeah.
Yes.
So that will be one cause that the patient may be fighting with the ventilator. When that happens, that's usually the cause. Just the wrong time. The patient took a breath at the wrong time. And so on. Here, airway diameter does change because the presence of the airway, it's a foreign object, right? So of course it will trigger some inflammatory response around the trachea. That will cause some inflammation and swelling of the trachea. So that may decrease the size of the airway now, because now the bronchial wall will thicken because of inflammation. And that may cause some obstruction, triggering the high pressure alarm. For here, you have a pneumothorax now. So now you have a collapsed lung, and of course that will trigger, there will be great resistance. So the tidal volume cannot be delivered because there is now a collapsed lung. By how much it's collapsed, we don't know. And of course, the bigger the size of the pneumothorax, the smaller the area of expansion for the lung. In case you don't know what a pneumothorax is, this is a condition wherein let's say this is your lung and this is the pleura, the sac around your lung. So let's say there's a hole here now because of barotrauma. So it ruptured your lung. Air now escapes out of the lung with each breath delivered. So now the lung, the pleura, has air escaping here, and that air has nowhere to go. So that means your lung will now be this big, and all of this is air. This is now the size of your lung. That's your heart, and this is the other lung, which is normal. So this is now your lung, which is partially collapsed. So of course, when the vent delivers the breath, it encounters a lot of pressure on the other side, which is that the lung is no longer inflating because of all this positive pressure here. This is now your pneumothorax, right? And so on. The other of course, is the low pressure alarm. So in low pressure alarm, it's the opposite. Instead of encountering resistance in low pressure alarm, there is now no more resistance. There's supposed to be resistance, but now the vent is not encountering any resistance at all. So that will, of course, be low pressure. These are your causes. There's a leak in the tubing, or the patient stopped breathing, or there's a cuff leak, or maybe the patient extubated themselves. The patient is awake and pulled out the tube. So the tube is on their stomach or on the floor. So there's no more pressure. Then you get a low pressure alarm. Any questions on alarms? Again, look at the cause and your corresponding actions. We discussed this last week already, but I was referring you to chapter 28 for the indications for suctioning. Here are more indications. Some of them are redundant. Tracheostomy care is in chapter 28, and this was already mentioned also last week to prevent pressure injuries in the airway or in the mouth. The tube must be repositioned. So while every time you do mouth care every 2 hours and you turn the patient every 2 hours, you may also reposition the tube every 2 hours. Don't attempt to move the patient by yourself. You need a minimum of 3 people to move the patient. One person should be at the head of the bed, stabilizing the tube while you turn the patient. Complications now. I won't test table 32-6. I'll test this part right here. So these are your common mechanical ventilation lung problems. Baro means pressure, so that's pressure trauma. We have volume trauma, meaning this is the tidal volume. This is usually caused by a migrated tube. The tube is not, the ET tube is not 2 inches above the carina. The tube is pushed down into one lung. That's usually the right mainstem bronchus. So all your tidal volume is going into the right lung instead of both left and right.
That's value trauma, Professor?
Shear in, yes. What was the question?
For the ET to going into the right mainstem bronchi, that's relative to value trauma, you said?
Yeah, volume trauma, meaning your tube is it's right here. So damage to the lung by excess volume delivered to one lung. Usually the cause of that is a displaced ET tube. The tube was pushed down too deep.
Okay, and what?
Go ahead.
So what would cause the first one, the barotrauma? Would that be like a high pressure support?
No, it's more of a, when the lung gets more stiff, you know, the lung compliance decreases. Let's say the patient's lung goes bad during the therapy. So let's say our tidal volume was 400, but then the lung got stiffer. Patient develops pneumonia, for instance. The lung now gets stiffer, so it cannot take 400 ml anymore, because most of it is the pressure, of course, that will rupture the lung, because now it's become so stiff, but the pressure from the vent remain the same. Although the high pressure alarm will go off first, sometimes this may happen before the high pressure alarm goes.
All right, thank you.
And then the rest, please read on your own. For, I gave you an example earlier that the patient may develop ARDS either before intubation, or they could develop it during intubation. Let's say they develop pneumonia, and then from pneumonia, they develop ARDS as a result. The patient will be, remember to feed the patient, please. If we doctors forget, be a advocate. Call them, say, hey, we forgot feeding. We got to give orders for nutrition. This is a stressful event for anybody. So the patient is, any ICU patient is at risk for what we call stress ulcers or Curling's ulcer. So every ICU patient must receive proton pump inhibitors or at least H2 receptor blockers. They have the same action. The difference is the way how they work and also the duration. The H2 receptor blockers only have a 12-hour effectivity, whereas your PPIs have a 24-hour action. I honestly don't know why we still keep H2 receptor blockers when PPIs already do the same job. All right, so we have pneumonia is a #1 complication of ventilating a patient. So Joint Commission developed a core measure for preventing pneumonia, particularly VAP, that's ventilator associated pneumonia. So we have a ventilator bundle set. These are your bundle. So always maintain a head of the bed up 30 degrees, oral care every 2 hours, ulcer prophylaxis, aspiration prevention, which is already the, besides the head of the bed elevation, always think about your cuff. Remember, the ET cuff has secretions above it. So before you deflate the cuff, make sure you suction the scrotal area. If you can't picture that, let me. So this, let's say this is Michael. And this is the airway. Now the tube, remember the ET tube, let's say this is the cuff. Okay, and this is his airway. There are secretions here, okay, above the cuff. And this is the tube. Before you deflate the cuff, make sure you suction this area first, because we have secretions trapped in there too. Because this is the mouth, this is the tongue. So we suction this, we clean this all the time. Don't forget to area periodically. And then especially if you make any adjustments to the cuff inflation pressure. So before you perform any deflation of the cuff, always think about the secretions that are trapped here. So you have to suction that before you do this, because we don't know how old these secretions are. Definitely, if they make themselves, if they find their way into the lung, you're guaranteed pneumonia. You have that is rich in bacteria there. Our mouth is probably dirtier than our rectum. And of course, do your usual pulmonary hygiene, just like any other respiratory patient. The others are self-explanatory, muscle deconditioning. Remember that the longer the patient remains on the ventilator, the harder it is to wean them off of it. So always attempt weaning, because otherwise patient will become ventilator dependent, and they'll just go downhill from there. Muscle deconditioning will follow. We're not just talking about muscle deconditioning in regards to the skeletal muscles, the legs and the arms, but the diaphragm as well.
Professor,
Yes, ma'am.
is the ventilator patient can be ambulate? Can we do that? We normally don't do any ambulation for the ventilated patient, right? They're always on their bed. Never seen.
Remember, yeah, it is possible. Remember last week I said 10 if the patient's on a vent for longer than 10 to 14 days, we switch to a tracheostomy. Yeah. Yes, the patient can be sitting up on bed. They can even ambulate. Of course, these are better patients, you know, but unfortunately their lungs are not working well enough. So they can be up out of bed. And you can put them on a chair, but still on a ventilator. But all of these patients are already having tracheostomies. We just can't wean them yet because their lungs are so weak. But that will help promote the weaning. Once we get them out of bed, they're no longer laying down. So that means we have no pressure ulcers. We have no muscle deconditioning. Okay, the patient remains and they can get stronger and stronger. So that'll be great. No, if we can get them out of bed. Did I answer your question, Ms. Lam?
Yes, thank you.
Okay. My only question for extubation is the procedure. So of course, the patient is weaned. We determine that the patient is now breathing independently. They don't need to be intubated anymore. So the procedure itself is we hyperoxygenate the patient before we remove it. Remember, again, suction the subglottal area because now we're going to deflate the cuff, right? So it's dangerous when we deflate that thing. All those secretions will cause the patient to aspirate. So that means you do that suction first, and then just, where is the, right here. So hyperoxygenate. So remember to suction ET tube, especially the subglottal area and the mouth, and then rapidly deflate and take out the tube, and then instruct the patient to cough. The coughing there is important because we may miss some secretions. Let's say right after we suction, there will be secretions there again. Because remember, the presence of the tube will always stimulate secretions. So just after you take out the tube, patient is instructed to cough. But don't worry, you don't have to tell them. They will cough on their own anyway. But just remind them to cough. And they have to be on oxygen nasal cannula for a while, and then you monitor for signs of complications. Let's say stridor, for instance, right here. So that means the patient may need to be intubated again. Hopefully it doesn't happen. But you just monitor those for, those are rare, but may happen. All right, so position them, semi-colors, breathing exercises. Just make sure they remain strong. Okay, so do breathing exercises as often as possible. Give them the incentive spirometer. All right, because we don't want any setbacks. And that's it. Any question? Let's take a break.